dialed in early, if you could take a moment to complete the poll on the right-hand side of your screen, that would be great. You may need to expand the polling function by clicking on the triangle to the left. Healthcare Foundation, for those of you who just dialed in. We have a poll on the right-hand side of the screen. You might need to expand your polling panel to see it. If you could take a moment and complete that poll, that would be great. And I will go ahead and ask Kanel to start the recording of the webinar now. Okay. Welcome, everyone. This is Giovanna from the California Healthcare Foundation. Those of you who have dialed in know that this is the monthly California Improvement Network webinar. And we are focusing today on the patient experience. And the CIN has done, and CHCF have done a lot of work over the past many years on supporting patient experience improvement in California. And we've had at least a couple of webinars on this topic over the past couple of years. And we wanted to revisit it today because there's so much going on in this area, especially in the safety net, and wanted to highlight the hard work by Golden Valley Health Centers and some of the exciting work that we're doing. And we'll be really interested if folks want to share in the chat function work that they're doing, questions that they have about patient experience in general. It doesn't even have to be about Golden Valley, but would love to have a dialogue going on during the Q&A session at the end. Before we get there, a few housekeeping functions. As you know, this session will be recorded, and a week after this webinar today, we will post the slides and the recording on our website. We will also send an email to those of you who have registered for this webinar, who submitted your email address. You'll receive an email with the slides and a link to our website that you can share with your colleagues if they were unable to make today's webinar and you want to share with them what you learned. To ask a question, please use the chat function on the right-hand side of your screen. It would be great if you can share your question with everyone, so use the chat to all function. That way folks can see kind of what's queued up. If you are having any technical difficulties or you have a logistical question, please feel free to just chat to the host or chat to the presenters. We are really excited today to have two speakers. We have Elizabeth Morrison, who is the Director of Talent and Culture at Golden Valley Health Centers, and she is joined by Connie Santa Rosa, who's a Patient Services Representative at Golden Valley Health Centers. And I'll just share a quick bio for Elizabeth and a brief bio for Connie Santa Rosa, so you know kind of a little bit about their background and the perspectives that they're sharing. Elizabeth Morrison's the Director of Talent and Culture at Golden Valley Health Centers, which is a large community clinic system in the Central Valley. She leads the organization in developing and maintaining a culture of engaged employees and patients. And indeed, you can tell by her title that it's a unique organization putting resources into having a leader of talent and culture, and I think that's really exciting. Elizabeth is a licensed clinical social worker and master addictions counselor. She obtained her bachelor's degree from Penn State University and her master's degree from UCLA. She developed Golden Valley's robust integrated behavioral health services in 2005 and was the director of behavioral health services until last year, 2012. She's also a faculty member of the Institute for Healthcare Communications, IHC, and IHC does a lot of training on communications with patients, communications with staff, and how to improve that in pursuit of patient experience excellence. Connie Santa Rosa is a patient services representative, or AKA receptionist, at Golden Valley Health Center, and she's been there close to 2 years. And we're really excited to have these two viewpoints on the phone call today. So I will turn the ball over now to Elizabeth. For those of you who have participated in many CIN webinars, there's a little bit of a different function today. We're going to be sharing Elizabeth's desktop, so you may see a pop-up in the window that says return to sharing if you don't see Elizabeth's desktop. So I will pass the ball to her.
Okay, thank you, Giovanna. Can you hear me okay?
Yeah, I can hear you great, and I think Kanel just needs to get your desktop shared.
Oh, okay. Is there something I need to do?
Yeah, Elizabeth, can we do the, if you can go up to the top and click on share, and then go down to my desktop like we practiced earlier?
I don't have a share anymore. I don't have a share.
Just on your desk. Can you go back to the WebEx window
Uh-huh.
the intro slides were shown?
Okay.
And then
Okay, there it is. Thank you so much.
There we go. Okay, great. Okay, we're all set. We see your desktop.
Oh, you do? Okay.
Yeah.
Well, hi, everybody who is on the call. I really appreciate everyone who is taking time out of their busy day to be here for this. Connie Santa Rosa is a receptionist here at Golden Valley, and she's been really involved for the last couple years in some of the employee engagement and patient experience experiments and pilots and movements that we've been doing. So I asked her if she would be here with us, and a little later in the presentation I'm going to show you a picture of her so you have a picture, and she's going to talk a little bit more about her experience of being a part of this. So I just want to start with a short story. It happened before Connie was working here, actually. I just told her the story when we were looking at this picture. These are my kids. I had just started working. I've worked at Golden Valley for 8 years, but I had just started working at this clinic here seeing patients. And my son had gotten really sick. He had a really high fever, and my husband texted me and said that he wanted to take him to the emergency room. And I said, no, bring him here. Bring him to my clinic. You know, I talked to the doctor, and they'll squeeze him in. Well, I didn't get to see him that day. I was busy seeing patients, and so when I got home and asked him how the visit had gone, my husband said to me, I hate that clinic. I'm never going to go there again. It was dehumanizing. And when I talked to him about it, it didn't have as much to do with the wait as I think we used to think in terms of patient experience. It had to do with being ignored, that he didn't get greeted and didn't get a smile and didn't get any friendliness. And then while he sat, which was for a pretty normal amount of time, about 45 minutes, nobody spoke to him or said anything to him, and he felt dehumanized by the experience. And I felt a lot of shame about it because this is the clinic that I see patients at. And then I felt really sad about it, just knowing that that was, generally speaking, the experience that most patients had. And that's where 3 years ago, I have always had a really, really high interest in front office and reception because I feel like it's the most important part of the patient's experience and the one that in general we think of as the least important or don't think of. So I'd always had a really high interest in it, and that's when I started talking with my CEO, and we started talking about creating a job that was focused specifically on employee engagement and patient experience. And when that started about a year ago, we took off running with the front office reception experience. So I just want to talk for a second about empathy because that's really, I think, what we're talking about when we talk about feeling basic warmth when you walk in someplace. So the idea of feeling initial warmth in a connection when you walk into a clinic, that there's a show of goodwill. You know, you feel like people have your goodwill at heart, and that there's the absence of overt judgment, which would be the opposite of empathy. And at Golden Valley, we've spent quite a bit of time training primary care providers in empathy conveyance techniques. It really helps with litigation rates, obviously, for those of you who know the literature on malpractice and litigation. People sue because they don't feel like you cared about them. But more importantly, it dramatically impacts the patient experience. And so a lot of the empathy conveyance skills we train for our primary care providers in the last years has been in the context of motivational interviewing and some of the basic ways to show empathy. We have not, until recently, looked at the fact that most patients feel empathy towards or feel empathy from a clinic or a system, not just from the provider. It's how they feel about the clinic, how they feel about Golden Valley, how they feel about the Tenaya Clinic, which is the name of our clinic. So empathy conveyance, as I'm sure many people on the phone call know, empathy conveyance is turning out to look like the biggest predictor of treatment adherence for patients. And it's certainly now outweighing socioeconomic status, it's outweighing age, it actually is outweighing addiction in the literature. So whether we feel like people care about us and they've conveyed that successfully is a primary driver of treatment outcomes. The second bullet I'm going to talk about a little later in this presentation, which is it is a measurable clinical and technical skill. It's not just about whether people are nice people or not. Everybody has empathy. The question is, how skilled is someone at actually conveying that? And we can measure that and look at that and hire for that and quantify that. And then the reason that Connie is here with me today and the reason we're talking about what we're talking about is there's some emerging literature and my own really strong belief about this, that the staff is equal to and some emerging literature greater than impact to the provider in empathy conveyance, meaning studies of nurses in hospitals, it looks like their empathy conveyance techniques have a bigger impact on treatment outcomes of patients than the provider's empathy conveyance. And so I really think as the years go on, we'll see more and more what that looks like in terms of our staff that are answering the phone and making appointments and greeting our patients as they walk in the door. So, of course, our cycle times here at Golden Valley, by the way, has about 27 clinics. We have about 115,000 patients. And so the clinic that we're talking about, we had 2 pilot sites with some of these things I'm going to talk about. Most of the things I'm going to talk about have been rolled out to all sites or in the process of that. But in general, our cycle time is about 58 minutes, and the average time with a physician is 9 minutes. So the majority of the patient experience is in the waiting room with our receptionists. So we did some baseline data about, so the majority of patients' experience is in the waiting room, and it's with the reception staff, and these are very basic tenets of empathy conveyance, would be looking at someone, eye contact, smiling at them, and a greeting, a salutation of some kind. And so we gathered some baseline data of our 2 pilot sites, and what we found out is that 1 in 5 patients were even being looked at when they walked in. Only 1 in 10, slightly less, were smiled at, and that only slightly more than 1 in 5 were even getting a good morning or a hello. So in terms of, like I said, even the most basic forms of showing goodwill or caring or empathy, we're really, really low. They're really low. And part of the reason I've been so, I think, free in talking about and sharing this data is that we have a lot of really great staff. So the question is, what's happening in the system? What is happening in the system that this is occurring? So we developed a series of interventions. Some of them we feel like have, we've gotten just great return on investment in. Some of them are still pending, and some of them, they didn't work out like we had hoped. And I'm going to talk about just a couple of the big ones. The first one is that we wanted to remove the barriers between the front office staff and the waiting room. The waiting room in most places is what I would call a dead zone. And when I say most places, most of the clinics at Golden Valley, but quite frankly, most of the healthcare settings I've been in anywhere, including private offices. The waiting room is this sort of dead zone where people sit and don't talk to each other, and babies are crying, and people are scared, and they're tired, and they're largely ignored. And it's a fairly not great experience for most people. And that was certainly the case with us. We have buzzers on the door, so you can't even get back into the back office, until you're buzzed in, and this sort of, desk that blocks you from even being a part of that experience in the waiting room. So at one of our pilot sites, we removed the desk. We actually just spent $1,800, incredibly cheap. It was during, we're in a financial crisis like everyone else, and this was almost a year ago, and just took out the desk. And we really wanted to get some more porousness between the front office and the patient. So we didn't do that at this clinic here, although we have estimates and plans, and it's in the works for that to happen here as well. And actually, they're taking down a desk at one of our clinics about 20 miles from here as well. But the one clinic where we've actually done it and been able to study the impact, the staff were the ones who immediately responded that they felt much closer, emotionally much closer to patients. So it really made a difference in that way. We have receptionists who work in the waiting room. what we realized from that data on smiling and eye contact and greeting is that if we have a bunch of great staff and they're barely looking or acknowledging patients, then it's really not about them not performing or being bad people. It means that we put them in front of computers behind desks and loaded them up with so much work and evaluated them on that work and disciplined them on getting that work done that really it's the last thing that they have time for. So we realized we had to change the system. So this is actually the clinic that both Connie and I work at. This is a picture of a staff member who's working in the waiting room. We have a staff on the other side of that desk. That desk will be going away, of course, but who actually greets patients at the door. There's no sign-in sheet, takes down the patient's information, has a cart with bottles of water and, you know, crayons for children, and can kind of manage flow and talk to people and keep them abreast of their wait time and just generally actually be with patients. Of course, the other piece about this, everything I'm talking about in terms of this lack of empathy or caring that we were able to convey to patients in any meaningful way, you can imagine, I'm sure people who are interested in this type of webinar probably know that this is the deal is that, generally speaking, that's the way we treat our employees as a culture. And that, so I think in general, it's almost exactly the same, that our employees typically, you know, in general don't feel a lot of empathy, I think, from, I'm talking about the organization as a whole, just systems, and that there's kind of a focus on them being, you know, robotic and hiring bodies and doing their jobs. And so patient experience will be roughly equal to employee engagement. And so, you know, we can push employees to be nicer to patients, or we can, and that means we need to equally focus on employees and how they're doing and what we can do for them and what their experience of their job is. So here's a couple of the things just in general that we've been focusing on, and I wanted to ask Connie if she can talk a little bit about some of these things and just her experience with the focused efforts we made toward employee engagement starting about 1.5 years ago.
So I'm also going to start off with a story. 2 years ago when I started, I wasn't very welcomed by the employees here. I walked in, met everybody, didn't feel the connection, or they didn't feel the connection with me. It just wasn't warm, inviting. Over time, I started thinking, if this is how they treat a coworker, an employee here, how do they treat our patients? So Elizabeth brought on all these pilots that we are doing and been working on, and the changes were pretty big, starting with the greeter in the waiting area, the happy patients, being our patients coming in with smiles. They already know what to expect from us. Made the employees here that we have now happy to be here, not just to be here for a paycheck, but to be part of the organization, to have input in what's going on, that Golden Valley is interested in what we have to say and what we want, to be able to put plenty of input of what goes on in our environment.
I'll show you guys a picture of Connie. This is Connie in the front there, in the forefront. Sitting just behind her is Karina. You can't see the person in the waiting room right now, but there's always somebody in the waiting room. So the two of them have been here for the whole time that we've been working on this. And one of the things about Connie that I remember is the very first meeting that we had, you know, just in a meeting with employees where we were saying, hey, what do you guys think would be, you know, what's your guys' vision about how you'd like it to be for employees here, or how you'd like to be for patients here? This last bullet here is when we're meeting and talking about improvements in the clinic and our vision for the clinic, we don't make any distinction between what's for employees and what is for patients. So we don't, you know, only talk about things that we think will be helpful to patients, and we don't only talk about things that will be important for employees, but really we see those things as roughly equal, and many of the things we're talking about toggle kind of back and forth between these things. And one of the first things I remember when Connie was brand new, she said, I don't know, I think we should be able to offer our patients coffee, you know, and it was November or something, it was cold, and so, you know, the next week we, you know, rolled out the coffee cart and, you know, said, you know, let's give that a go, let's see how that goes. And so I think that it sounds so simple, to have regular meetings and find out what employees want. It sounds so simple, and it was definitely not happening at this organization. So here's some other things, you know, that have come out of just employees meeting and what they would like to see and what they would like to do here. But can you talk about the lighting one, Connie? I think that one's interesting.
Oh, yeah, definitely. We started off with the lighting in the front office. We brought out some lamps, turned off the overhead lights, which were pretty bright, you know, hospital setting-like. It's just business-like. But we wanted a home setting, a welcoming setting for our patients. And a big difference it made when we brought out those lamps. People came in, patients came in. What did you guys do here? What's the difference? And all that we did was change the lighting. We added a few frames, and they felt comfortable. They were at ease. They said they felt like they were at home. They were part of the family. They were just overall happy, and which made us in turn happy of the little changes that we made for our patients and for ourselves. A more comfortable area to be at.
Yeah, that's what I think is interesting about this one is, you know, we ditched the overhead lighting and got these alternative lighting we want it for the waiting room. It's a little more expensive to figure that out a little bit, but this was actually for the area that the receptionists work in. And the impact in terms of how the patients responded to that was really strong. It was really interesting to me. And very, very, very inexpensive. I mean, we're not talking about major remodels with any of these things. You know, one of the things that's, I think, kind of interesting is that we removed the buzzers from the doors. I still remember I was in leadership or something I don't know what it was. Now it's been like 6 months, and I just said, why do we have doors? Why can't we remove those dang doors? You know, there's just, get out the desk, remove the doors, and you know, that didn't fly. Nobody wanted to do that. And but I said, why do we have these buzzers? You know, it doesn't really provide security. It provides a barrier. It's institutional. And so I asked these guys up here tonight, I asked them, I came in one morning and I said, hey, you guys, what would you think about getting rid of the buzzer? And one of the receptionists, Karina, who was sitting behind Connie, just reached under the desk and disabled it. And I thought it would be some big work order, you know, try to really swing them, and she just disabled it. And I said, let's just give it a try today. And the difference that something like that has made, right? Connie's nodding.
Yes, it's true. Patients can come in if they need to go to the restroom, come to our front area and ask us questions. They feel, what's the word I'm looking for? That they're able just to come in and feel welcomed without having to put a barrier there that, no, you can't approach anybody, you can't talk to anybody. But the fact that they can just walk in that door, I want to talk to this one, I want to talk to her, or so-and-so, it just makes the experience more greater for them.
Yeah, and the nice thing about that has actually been rolled out to all the clinics. And so it just went kind of like wildfire. It was really interesting. There's not a clinic in the system now that has buzzers. I'm going to skip over that third bullet. I'm really interested in that one, but I want to get to some of the data. One of the things that we did, and Connie and I were just in conversation about this morning because we're hiring, they're hiring for another receptionist at the clinic here, is that in terms of real cultural change around prioritizing empathy conveyance and warmth and people skills, we made the change years ago where we hire providers based on this. We might not do it perfectly, but the entire interview and selection process is based around essentially people skills. But we really hadn't done that with the other staff. And so we did entirely revamp the interviewing and hiring process. The job descriptions and evaluations are, as we speak, in process where they're being changed to prioritize these particular skills. And then in terms of a culture change, regular data and data sharing around empathy conveyance. So I'm going to show you what that looks like. This is just an example. This is September's data. This is just a list of a handful of our clinics. And we now have an auditing system where supervisors who directly supervise staff at our clinics once a month go to another clinic and sit in the waiting room. They're not secret shoppers. They do have their name tags on. And they audit how the receptionists are doing with greeting and smiling and eye contact. And back to that original data that I showed that looked like, 1 in 10, 1 in 5 patients were even getting eye contact. That was, there were some of our clinics that we were collecting data on that were as low as 4%. So that actually went down from there. So until you measure something, right, nobody thinks it's important. And something really changed once we started developing a wholesale auditing system where it became as normal as auditing immunization rates, or as normal as looking at accounts receivable, that now we have this data that we gather every month, in addition to the side benefit of supervisors being able to see other clinics that they might not normally see, how other clinics are doing and how they're doing it, and looking at their staff and being able to give feedback, but that we also then post this data in a transparent way. And of course we work with clinics and with supervisors on coaching and performance improvement, all of those things. But just the mere fact of gathering this data and sharing it has fired up a number of our other clinics. We have a huge clinic, a really big, it's about a 12 FTE clinic with all kinds of specialists there. It's one of our largest clinics. And the chief medical officer works there along with the director of provider development, both amazing leaders. And when their clinic was audited, 40% of their patients were even getting eye contact, and the greeting and smiling was much, much lower. It was in the 20th percentile. And I think getting that data and sharing that data with everybody really turned a fire on about, is this how we want this gem of a clinic, where these wonderful people work, and what can we do about it? What are the gaps? What are the problems, and what can we do about it? So you can see these numbers we were not unhappy with, to be honest. Lots of improvement, of course, to be had, but we've been working on this for a while, so it's significantly different than it looked like a year and a half ago. You guys are probably familiar with the Pulse survey, and this is old data. We're actually sending out a new survey, and we will have brand new data within a couple weeks. So the timing, I wish we had it for this phone call. I was just asking Connie and some of the other staff here where they thought we would be this time around. So, in about a 7-month or 6-month period of time when we started down this road, we wish these numbers were better, but we actually doubled. We were able to almost double in both cases how many staff would recommend this as a place to work and how many would recommend to come for care. And for those of you who are familiar with the Net Promoter Score, it's a little complicated how they figure it out, but generally speaking, the blue is our baseline. And like I said, we're giving it out again, and our expectations is that we'll have significant improvements again. This is just
Elizabeth, can you hear me?
Yes.
I was just going to say, I think there might be some interest, and there might be folks on the phone who are not familiar with the Pulse survey and maybe don't know about the Net Promoter question. And
okay.
I wonder if you could just take a minute or so and kind of talk about how you've been measuring the patient experience and how you administer the surveys.
Sure. Well, with the patient experience, we're using CAPS, probably like most people, and I have that data as well that I'm going to share after this slide. But the Net Promoter Score has typically, I'm sure people know more about it than me on this phone call, but is typically being used outside of healthcare. And now as part of a California Healthcare Foundation patient experience project, we used it now. We've used it twice. We're going to use it again. And the Net Promoter Score really looks at what percentage of the employees are active detractors. And that really means, active detractor means so unhappy that they're probably outside of your organization actively deterring people from going there or working there. And ours were about 30%. So about 1 in 3 of our staff felt bad enough about this as a workplace and this as a place to, for someone to obtain care, that they were active detractors. And the way that they figure out those numbers that I showed you on this one is it's a little complicated because they sort of, subtract they take the neutral out and subtract the detractors from the promoters, who are people who feel so positive. They're actually, talking well and referring people to you. So it's been a really useful tool for us. We had not measured what you might consider kind of proxy measures for employee engagement before in terms of how employees thought of us. So I think measuring it all is incredibly useful. We did share this, of course, with leadership. We shared it with all staff. The staff were not surprised about these numbers. Some of leadership was, which I think is interesting. So yeah, that's been really, really helpful for us. And then the reason I put the real patient experience here is just because if we look at the baseline data for eye contact, smiling, and greeting, and where we are at 18 months, you know, we talk a lot about patient experience now, of course, in our field we do, and, you know, it always with these terms, the temptation sometimes is we feel, you know, we might lose, like, the real meaning of that. And for me, like, one of the most real meanings of the patient experience is when they walk into a clinic, do they get said hi to? I mean, do they feel any initial warmth, you know, or caring from this organization? So we were really, really happy with this data. We use CAPS. We don't have baseline data for CAPS just because we started this summer. So it's not like we have baseline data from before we started down this road actively with these interventions. But the reason I share this is, like I said, we have a lot of clinics. There's only 4 of them on this right here, and they're 4 kind of like-sized clinics. They're mid-sized clinics with about 4 FTE providers. But the reason I share this is Tenaya is the one here that's up above, up above 90%, about 96%. And here's the reason I share it. This clinic that we've been doing the most, you know, the most work on, even though many, many of these things have, like I said, have already been rolled out to other clinics, this clinic just left in the dirt every other clinic in our system. We were 20 percentage points over most of the clinics, and some of them 40 percentage points over. And I think what's really interesting about that is the wait time, the cycle time for Tenaya, this clinic, is 120 minutes. So we're twice as long as the average, as our organizational average. And I'm concerned about wait times like everybody else. I mean, you know, we have Coleman and, you know, I'm concerned about it. Nobody wants to wait for 2 hours for an appointment or whatever. But I think the interesting thing is I think the focus on wait times as if that is the patient experience, that if we get them in quicker, somehow it's a better patient experience. I really think this is the point, that the patient experience is whether people feel seen or feel caring or any empathy conveyed to them. Because to have scores like this when our cycle time is so long right now, which of course we're working on in other groups and other areas, I think is really significant. And I think it really shows that it's not necessarily the wait, it's the experience. It's the experience of the wait. And this is my mom and me. And the reason I shared this picture is because, and Connie and I, we just had this conversation yesterday, completely like having nothing to do with this webinar. But you know, I shared this with the staff too. You know, my mom, my dad died last year, and we bought my mom a little house in Modesto and moved her here. She's 76, and this is her and me at a Modesto Nuts baseball game. And you know, I work full time. My husband works full time, so she's you know, a little bit on her own during the day. You know, she moved from North Carolina, and she's trying to get herself settled here. And every day she's going to the DMV or going to the bank and getting stuff set up, or you know, having to like go places and get her life set up. And it just kills me. You know, I want to be with her. I don't. You know, I feel, I cringe. I think, God, is she going to walk in someplace? Are people going to ignore her? Are they going to be rude to her? You know, I just feel protective of her, and I think that, you know, that pulse score, you know, those pulse questions, would I refer a loved one here? And it's also the question that the National Health Service in Britain uses as a standard quality measure, you know, that they ask the staff in healthcare, would I refer a loved one here? And it used to be, for me, the answer was no, not unless I could highly manage that care, not unless I could, you know, not have them have to call in for an appointment and have Connie make that appointment and then buzz them in the back door and have them wait in my office and handpick their provider and blah, blah, you know. And so like Bridget Duffy from Xperia Health always says, like, what do people do that don't know someone like us in healthcare? And Connie was saying that too, you know, that when she came here, she wasn't sure she would refer a loved one either. And I think just to be able to talk about that openly and what that means and what kind of systems that we want to build together so that we feel great, you know, about referring people we love here, whether we're here or not, to kind of, you know, track or manage their care, I just think is probably the most important question for any of us. I think when we build systems for poor people, it doesn't look the same as when we're building systems, you know, for ourselves or the people, you know, it kind of objectifies that in a way that isn't helpful. So, Connie, do you want to add anything or say anything?
Yeah, like Elizabeth said in the beginning, yeah, I was very hesitant to refer anybody to any of the clinics at Golden Valley. Now, I have quite a few of my family members going to different clinics, and I'm comfortable for them to be able to go there, and I can say, hey, ask for this person, just show up, check in, and not feel that my family's going to get, ignored or just put aside, just faces made at them. I can now say that I know they're going to be welcomed, they're going to get smiled at, greeted, and that's a good thing for me. That I know that my family is going to be taken care of by an organization that cares, that really cares about their patients.
So I think that's all we have. We'd love to answer questions if anybody has them, or hear comments or other people's experiences with this kind of work.
Great, thank you so much. I do have a couple of questions in the queue that I'll ask you guys in a second. If there are other questions that folks have, please feel free to go ahead and chat them. If you had the system call you and you want to ask your question verbally or make a comment, I think you just need to raise your hand. But if you didn't have the system call you at your phone, then we won't be able to unmute you. So the first question is about, there are two questions actually, about your removal of the desk and removing the buzzer. And I'll just kind of read them to make sure I capture the sentiment. The first one was, I'm curious if any staff have provided feedback that they feel less safe with fewer barriers. And the second one says, I echo that question. We've had a few recent events where patients without appointments will enter the clinical area, or patients with demand stand around the clinician's workspace after their visit. Now folks want to put up more barriers, closed door, etc. How do you balance the openness and inclusion with safety?
Well, let me say something first, and then maybe Connie can speak to the staff's first response to this. I have a lot of really strong feelings about this. I actually oversee the de-escalation training for our organization and have written all of the de-escalation prevention protocols. And there's a ton of research in this area, much of it done in emergency rooms, but there's also a fair amount of research out there as well. And barriers do not keep us safer, period. And in fact, glass up between us and them, right, when people put glass up like at Social Security or at banks or something like that, they actually increase the rate of angry customers. So most of the things that our first reaction or our staff's gut reaction that will make us safer actually make us less safe. And that includes the presence of security guards, by the way. The presence of security guards indicates to everybody there that it's a dangerous place. And what that does is it creates a culture where it looks like that kind of behavior is normal. So there's actually no evidence whatsoever that security guards in any way keep things safer or de-escalations lower. So that's the first thing that I would say, is that there's no evidence that buzzers are helpful. There's no evidence that glass, that doors, that desks keep people safe. And so, not only do we know that in the literature about these things, but it's also our experience that when patients escalate and yell, and when we've had scary situations where a patient has threatened people or is in the back office yelling, this is, everybody's had these situations. It happens in retail. I mean, it happens everywhere. These things happen. We have a very systemic approach to how we deal with that. We have trainings in de-escalation. We have a system by which we warn patients when their behavior has been inappropriate. We discharge patients, of course, who have threatened, et cetera, et cetera. But the reason I want to say that is these things, the only way to lower the incidence of these things happening is increase staff confidence in training around connecting with patients. So I will give you an example that we have had less angry patients at this clinic since we have put a receptionist in the waiting room. But the very, very first time I mentioned putting a receptionist in the waiting room, the supervisor of this clinic, who is now 100% bought in and like a driver to everything that we're doing, her first response to me was, I don't want my staff in that element. Do you remember that?
I do.
And I empathize. I mean, you know, there's this feeling that it's us and them, and our staff has been really wounded in many ways, that they have sometimes been abused and we've done nothing, you know, as an organization, I mean. And so, you know, what do you expect? They, you know, they feel kind of wounded and scared, but the real protection is getting close and connecting. It's why they train people to make eye contact and smile when people walk into CVS, because they've been trained in loss prevention and de-escalation, and people are much less likely to yell or steal things if you make eye contact them and greet them when they first walk in. So I think part of it is really ourselves kind of challenging our own ideas about what really keeps us safe or doesn't keep us safe, and then helping the people around us and our staff, you know, not by arguing with them or telling them they're wrong for those feelings, of course, not, but really helping our staff understand that these things didn't prevent those things in the first place. And, you know, I was out at one of our clinics and I asked them, hey, how's it going without the buzzer? And this medical assistant said to me, well, I mean, I don't know, it's just, you know, I think we're scared. It had just been removed like the day before. She said, I just feel like we have patients wandering back here, and, you know, they just can come in anytime they want, angry. And she kind of went on and on about this for a minute. And then I said to her, and how often has that happened? Like, never or once. You know, it was so much in the mind what could happen, that it actually tends to have the opposite effect. So what do you want to add to that?
I mean, I was very hesitant when they said they were going to take the buzzer off. A lot of us were nervous. We were like, no, our patients are going to come in. You know, what if an upset one comes in? But like Elizabeth said, we were all been trained with, you know, using our cares and connecting with the patients. As soon as they walk in the door, a smile, eye contact, a greet, they're comfortable. And to this day, none of us are nervous about having the buzzer off. We feel comfortable when the patients come in. Patients feel comfortable with us. It's that the big word is connection with the patients. And we don't feel nervous anymore. We're just comfortable with everything. We want to be able to have them feel like they're welcomed here as family, and they do.
And then I guess the other part of that, this is weird too, because Connie and I just had this conversation too, which not in relation to this at all, but oddly enough, we had a similar conversation where we were talking about, but then the organization has to make sure that they, you know, are taking systemic action when the staff has been abused. And not having anything to do with the buzzer or the desk, but you can't expect the staff to walk with you down this walk if they don't know that we're also going to watch out for their well-being, and then we're not going to ignore it or act like that's just part of the job to get yelled at. No, we're going to document and call that patient and let them know that unfortunately that's beyond the limits of what's, you know, acceptable at the clinic, and you know, we certainly don't want to lose them as a patient, but if that continues, et cetera, et cetera. So, but I think the employee engagement piece is big here because, you know, it's not like the CEO came in and removed all the buzzers and said, guess what, guys, this is business as usual. No, we came in and said, what do you guys think about this? And would you be willing to try this for a day? And the desk being taken down at the other clinic, it was like a year of employee engagement work to get them to the point where they wanted it, where they wanted to try it. It's not like we went in and demolished and said, you guys, this is how you're going to work now. That probably would have gone really poorly. You know, we really had to sort of let them know, hey, we're just trying this. We want to hear how it's going. And you know, there was a point where two of them, I think, were asking for it. You know, they really, really wanted to give it a try. And then it's a really different dynamic, I think.
Great answer. We have several questions actually in the queue, about 15 minutes. I think we can probably get through them. There's a question here about how you conduct your Net Promoter Score survey. How often? Is it a paper survey? And how often do you do it?
Yeah, that's a great question. It's actually online, so it feels a little bit like a Survey Monkey. And we do not administer it ourselves. And that is only because it came to us as a tool through this particular grant that we were working for through California Endowment. Now, we're looking into whether we would like to keep using this as our tool and adopt it and give it out ourselves, or whether we'd like to switch to like a Gallup 12 or something like that. So we're not sure what tool we're going to use, but right now it's like a Survey Monkey. We send it out to all the staff. You know, it's completely anonymous, so we remind them of that. And then the data actually goes directly to the California Endowment right now. You know, if we owned it and we're doing it ourselves, you know, that would look different. But yeah, it is anonymous and it is online, so it's really easy for staff to do.
Great. Okay. Question about getting copies of the slides. Yep, we'll send those out to folks who've registered for this. We'll send you a link. In about a week, they will be posted along with the webinar recording on our website, and we'll send that out to folks who've registered for this, whose emails we have. Can you please talk a little bit about the mechanics of the process for the audience in the waiting room, kind of how you set it up and how it unfolds? And then a related question that I wanted to add in there is, do you have concerns in that auditing process about the staff changing their behavior, you know, the eye contact, the smiling, and the greeting when the audits occur, and how do you know that that doesn't happen after they leave?
Okay, I just want to make sure I understood the first question. The second one I really understood, like what are our thoughts about the impact on behavior change, you know, when the auditor is in the waiting room. The first question was about like a little more specifics about what the auditing looks like.
Yeah, kind of. I think this is a question about how logistics work. How often do you do it? Who do you send in? How long does it take?
Yeah, and you know, we've tinkered a lot with this, right? There's been a lot of different iterations of this. So we actually used patient and family advisors at one time, and that was really interesting to me. I was really for that. I really like that idea. Connie's smiling, just because talk about more interaction between, you know, patients and us, and like lowering that barrier and that boundary. It's just, and they got really excited about it. Like the ones who were doing it, you know, really liked the idea that they were kind of like involved in this level of stuff. But, you know, they're also volunteers, so it's a lot harder to hold them accountable to deadlines, and, you know, when they're don't fill out the paperwork right, you know, it's just, it's a little harder. So they're actually still doing some patient experience data gathering work for us, but a little bit more qualitative in terms of interviews, and we kind of moved away from them auditing. So we're using supervisors right now. We're using the supervisors, the direct supervisors of the staff at the clinics. And they're going to clinics that are not theirs. And we've done some training with them, and Viviana Lara, who works in the Department of Talent and Culture, has created kind of a bunch of different iterations of forms. We used to just collect generally, and now the forms, which I'd be happy to send to anybody who'd like to see them, actually separate the data by the actual receptionist. And this was a request by supervisors and even staff. Everybody wanted it separated, and it really makes more sense, because how do you know who's hitting it out of the park and really skilled with this, who's maybe too buried in work, who maybe needs coaching? You know, I mean, it was hard to really use the data in a meaningful way if you didn't break it down by the staff. There's sometimes 4 receptionists in a clinic. So there's you know, these specific forms that we do some specific training. There's a deadline every month. They're due on the 15th. They can do it anytime before the 15th. They have to, you know, watch a minimum number of patients walk in, and they, you know, sit in the waiting room and just kind of tick these boxes. So that's kind of how it actually looks. Now, I would love it, I think, to move toward having the staff do other clinics as opposed to supervisors, just because, you know, it's uncommon for staff to get to move around between clinics and to see other places and to see what they really like and what they really don't want to be like, you know. I mean, I just think I would really like that to happen. So I think that's the next iteration, is to see if we can get, you know, staff doing each other's clinics. The second question, I think, is a tough one. And, you know, like I said, we may go through different iterations of this where now we're doing a secret shopper at some point or something. So it's not that I think the data is perfect. It's just a brand new data gathering system. It's probably imperfect. My sense about it, because of the numbers we had initially, is that there wasn't a lot of behavior change based on that person in the waiting room with a name tag. Because really, when you're getting, you know, 20%, 9%, I mean, one of our staff went to a clinic, introduced herself as an auditor, and that clinic got 4% on greeting. So So my sense, at least in the beginning, was there wasn't a lot of alteration of behavior, but I think it's something that we need to think about and get some feedback from the staff about, and you know, we may alter that. So what do you want to say about that, Connie?
We're really busy, and most of the time, me personally, the last couple audits, I didn't even know the supervisor was sitting out there auditing us. Maybe one staff member did notice her there, but quite a few of us aren't even aware that they're sitting out there and doing the audit because we're so busy and we're, you know, connected with other patients and so forth. So, I mean, I believe the data, it's really good feedback that we're getting, and honest feedback.
Great, thanks. Before we go on to the next question, Kanal is going to end the desktop sharing so that we can go back to the initial slides, and so everyone can see the chat function a little bit better, and also so that for folks who are signing off from the call already, if you could take a minute and please answer the polling questions. There are some exit questions there about today's presentation, and we'd love to get your feedback. So for everyone, please take a moment to finish that poll before you exit. So one question that we did not get to about the Net Promoter Score was how frequent is it?
Oh yeah, I'm sorry. You know, we've been doing it we've done it twice. This will be the third time. So they're at about 8-month intervals.
8-month intervals. Okay, so you started at the beginning of the initiative and you've done it every 8 months. Okay, great, thanks. There's a question here about the greeter position that you were describing and how it works. Is there only one greeter at every site, and is there ever alignment forms for the greeter, and how is that handled?
Yeah, so we are continuing to develop that job description, if you will, and there is one right now at all the clinics that it's been rolled out to that are doing it, and we actually think that it's possible, ideally, that there would be two. But right now it's just one, even in our fairly large clinics with fairly large waiting rooms. And there is sometimes a line that forms, absolutely. And that is true when the receptionist was behind the desk too, of course. And the difference between that is that when receptionists were behind the desk and a line formed, it was very uncommon that the people in the line got acknowledged. And for those of you who have worked in customer service before, you know that that's called working the line, where the person in front of you is the person you're helping, and you go down the line with eye contact and a smile and say, I see you, I'm so sorry, I'll be with you in a minute. And that was absolutely not happening. I mean, I think part of it is, you know, we didn't train or set that as an expectation. Part of it is when you're sitting down and there's a line between you and the door, you know, and you're kind of madly flowing this person through with your computer, the chances of you being able to do that, even if you're a superstar, are pretty low. So I think the difference is when somebody's in the front, and when I have been out there and I have seen a line, is that they don't have a computer in front of them. They are taking down information in terms of, you know, saying, you know, good morning, and, you know, do you have tell me who you're here to see, that kind of thing. But they're able to move much more quickly through that line, and they're also able to actually make eye contact and acknowledge those people in that line. So what's your sense of that, Connie?
Our patients are willing to have a seat and wait until it's their turn because they've been acknowledged. Our greeter has smiled at them, made eye contact, and said, I'll be right with you. And the patients already know. They've gotten so used to knowing how our process works that we have no problems with a line building up. I mean, it goes quickly, and they have a seat, and then they get called up, and
yeah, that's the other thing that's sort of interesting, right, is when someone's actually out there, you could say, you know, please have a seat, you know, this woman who's carrying this big, heavy baby carrier or something. And then when you're ready for her, you know, they just walk over to her and say, okay, you know, I'm sorry, thank you for waiting. Or whereas, you know, when someone's behind a desk, you kind of just have to wait there. So we did a lot of gathering data from our patients when we made this change, a lot. And because I see patients here, like I spent 2 whole days seeing patients where every single patient I saw, I'd say, do you mind if I ask you a couple questions, you know, before we start? So I was doing my own kind of, you know, gathering data. But then these guys were, you know, getting data from patients, and we had people in the waiting room interviewing patients, and we got a lot of qualitative data from our patients about this. And the feedback was just off the charts. You know, there was just not one less than effusive comments about this.
Great, thank you. So we have about 3 or 4 more fairly substantive questions, so maybe we can go through them as quickly as we can. We have about 6 minutes left. Before we get to those questions, there were 2 requests for the literature, the studies that you mentioned, both about the safety issues with barriers and how they don't contribute necessarily to safety in work environments, and then also about empathy conveyance, what you were talking earlier about at the beginning of your presentation, its correlation.
Yeah, I actually have kind of a library of some of the better or more interesting studies on empathy conveyance that I'd be happy to send links to. A couple of them are meta-analyses, which is always nice. The safety issues, the best literature comes from the Nursing Association, who consistently, does this kind of research in the emergency rooms. And I'd be happy to send like the latest one about that. The most interesting thing about that finding was there's only one single thing that they could pinpoint. They didn't study empathy conveyance as a way to lower escalations, but out of all of the things that they studied, like panic buttons and bulletproof glass and all of these things that they studied, there was one single factor that seemed to lower the incidence of de-escalation really clearly, and that was how good the communication was between staff. Really interesting. It had very little to do with. So yeah, I'd be happy to send those things.
Yeah, why don't you send them to me, Elizabeth, and then when we send the email out to folks after this call, when the webinar and recording are up on our website, we can include those.
Great.
Okay, so 3 more questions, and you'll probably have to answer them very quickly, but we can always connect folks afterward. How are patients engaged in your work? Are they able to provide feedback and through focus groups or interviews or comment cards about the changes that you're making, or help you to think about the changes to make?
Yeah, there's a couple different ways. I would say one of the slightly more formalized ways is we have, active patient advisor groups. So we actually have a full-time staff member who, that's her job, is the patient and family advisor group coordinator. And we have these groups that, they're kind of centered around 5 or 6 of our different clinics. So like I said, that's where I went to for this pool of patients when they did some of this auditing for us, and now they're doing qualitative interviews with patients to get more in-depth look at patient experience. The CAPS data, is good. It just is. It's very focused in many ways on the provider interaction, I think. So our patients are, there's that kind of formalized groups that we have of active patient advisors that we can kind of pull into our activities. We also, 6 months ago, I think, was the first time, and now we do it regularly, where we have our patient, one of the patient advisors in interviews with providers. So 6 months ago was one of those things that, like, there's this group of us that always interview the candidates, and it was the first time that we had this patient advisor with us, and I was kind of nervous about how it would feel for everyone. I talked to everyone about it. I talked to the patient advisor, and it went great. And, really said a lot about the candidate, too, in terms of how they responded to that. So they're involved on that level. And then particularly with the changes I've been talking about now, like today, like I said, we spent a lot of time, I think, gathering and doing patient interviews at both of these pilot sites, and also actual surveying. Like every time we would even pilot something small or new, we would work up this 6 or 7 question survey and get 15 patients on their way out the door and ask them what they thought of it. So we also have that kind of PDSA rapid kind of data gathering. And then in some ways there's just that really informal piece, like Connie's, usually the person who is saying, here's the feedback we're getting from the patients about the lighting or something like that, right? We'll sort of get it that way. So there's kind of informal and more formal ways.
Great, thanks. Last question, I'm going to try and kind of connect to questions that are on here. There's a question about kind of how you implemented the changes in the clinics and how you rolled that out, and I know we're very close to it, but if you could give a high-level answer to that about how was the training structured, did you start off with motivational interviewing with practitioners, the empathy training, just at a high-level overview, and I think that's related to another question, which is that the intervention that you talked about today is really focused on the front desk waiting room area, but you've obviously mentioned that you're doing a whole host of things to improve the patient experience. And so I think those 2 questions could probably be answered in the same answer.
So it sounds like kind of those questions are around like almost like sequencing, or
Yeah, I think the sequencing and the breadth of all of the things that you're doing, it's not just about this front desk waiting area that you've changed. You've mentioned many other trainings that you've been doing with staff and providers.
Yeah, I know it's a hard question. I was just trying to decide where to start. Well, I mean, I'll tell you a couple of the big things is 4 or 5 years ago, we changed the job descriptions to reflect a focus on people skills, and we changed every single job description. When I say people skills, I mean that really broadly, empathy, conveyance, customer service skills, to focus on that. And we adopted a standardized relationship skills training. You could call it a customer service training. We call it, Connie mentioned it when she was talking, the acronym is CARE. It's from the Institute for Healthcare Communication. And I think those two things, changing the job descriptions to reflect this particular skill that is at the heart of kind of everything, and adopting these structured, mandatory, kind of curriculums around that this is just part of our culture. Training, of course, doesn't necessarily change behavior, but it sure gives you a language and sets an expectation and starts to shape a culture about what, what we value here. So we do the motivational interviewing training with providers. We do a de-escalation training with front-level staff and supervisors. We do the CARE training, which is focused on the relationship skills, connecting and appreciating. So I think all of those things are the kind of foundation in which this Petri dish happened in the last few years. So yeah, there have been there's a lot of things. Yeah, that's really true.
Great, thank you. Well, we are at time. Thanks to everyone for joining today. This was a really robust conversation. It's great when we have so many questions because it helps us to kind of understand what's going on out there, what are people most interested in, and I think it just makes it more lively for folks to listen in. And thank you so much to Connie and to Elizabeth for sharing the wonderful work that you're doing today. And if folks have questions, feel free to visit the CIN website. You can find contact information on there if you folks want to reach me. And thanks to everyone again. Have a great day.
Thank you, Giovanna. Thank you.
Thank you.